Hello everyone, now we continue our discussion of the cardiovascular high yield question summary. Okay, so now another high yield scenario. Let's say another patient came in, 32-year-old male, came in when with heart palpitations. Okay, so they will ask about like what auscultation, like when the patient sit up, lean forward and hold breath at end of expiration while placing the diaphragm. So basically they want you, what kind of murmur, what's the best auscultated at this, what valve best auscultated, what disease best auscultated in this position, right? So that's pretty much what they want. Okay, and the answer for that is because when you sit up, end of expiration, lean forward, this is make the aortic regurg murmur heard best. This one, aortic regurg murmur. So this is about like when each one. So we have the regurg, aortic regurg is a diastolic murmur. Other diastolic murmurs, mitral stenosis. The one that are systolic, usual aortic stenosis, mitral regurg, HOCM, mitral valve prolapse, atrial septal defect, ventricular septal defect. All of these are systolic. The only diastolic murmur is aortic regurg, mitral stenosis. Okay, everything else is systolic except PDA is continuous murmur, peritonitis arteriosus, machine-like murmur. All right. Now we got another case scenario. We have 61-year-old male, woman, history of heart disease or stroke, no medications, and the question is that how to decrease blood pressure or decrease blood pressure, decrease hypertension. So because they want to discuss like what are the lifestyle changes that are very helpful to treat hypertension. So the best thing is DASH diet. Okay, dietary approach to stop hypertension. So what is that DASH diet? DASH diet is high in fruit, vegetables, and low in saturated and total fat. This is increased like by 11 points blood pressure, 11 mmHg. Weight loss below 25 BMI, this is very good too. Aerobic exercise 30 times per day for 5 times a week. This drops by 7 points. Wow, that's crazy. Dietary sodium restriction less than 1.5 to 2.3 gram a day. This decreases blood pressure as well. Alcohol limitation, less than 2 drinks a day per man and less than 1 drink a day per woman. This also helps to prevent hypertension. Okay, so that's one thing. Okay, now another case, you will see they will bring you another patient, 75 or 77 with diabetes and AFib, and they tell you what's best next step. This patient, you do oral Eliquis or SCOT-XA inhibitor, factor 10 inhibitor you can do. This basically they want you to know the child VASC. So if he's above 75, this is 2 points. Diabetic, that's another point, it's 3 points. So more than 2, this is high. Other points, like if they have stroke, that's another 2 points. If they're vascular, prior MI, this is 1 point. Age 65 to 75 is 1 point. Female, just like being female, this is another point. CHF hypertension, this is another point too. Female, maybe they're more hypercoagulable, so you gotta watch out for that. Alright. Another thing, like you see, okay, in that case, you see 25-year-old woman came in with loud S1, low pitched, mid diastolic, rumble, and snap after S2. and they will ask you about diagnosis. What do you think causes mid-diastolic rumble and snap after S2? This is mitral stenosis. Now, this is a good opportunity to discuss like a little bit about mitral stenosis. How can that happen in 25-year-old? Usually rheumatic heart disease, age-related calcification, radiation-induced. Post-exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis, pulmonary edema, right-sided heart failure, lower extremity edema, atrial fibrillation, increased risk for systemic embolization, and the way you diagnose a SNAP after mid-diastolic rumble at the apex. Echo cause increased transmitral flow velocity, and treatment percutaneous valvotomy or surgical repair / replacement. Alright, that's another question. Okay. Another case scenario, okay. They bring you another 42-year-old woman. Came like she want to do tooth extraction, right? Want to do tooth extraction, but she's on warfarin for mechanical valve on INR 2.6. And they will ask you what to do. You stop the warfarin, continue. What do you do? So continue warfarin and dental extraction. And why? Because you want to know, there are, like, you gotta understand as a physician, there are high bleeding risk surgeries, and there's low bleeding risk surgeries. The one that are low bleeding risk, arthrocentesis, coronary angiography, outpatient dental surgery, cataract surgery, minor outpatient procedure, excisional skin biopsy. These you can do them. If you can get a haircut, you can do those. High bleeding risk like open heart surgery, abdominal vascular surgery, intracranial or spinal surgery, major cancer surgery, urologic surgery. These are high risk bleeding, so you want to stop. But this case scenario is small, like these small surgeries, you don't need to stop it, so you just watch it. Alright, so another case, I'll bring you 68 man with chest pain with exertion, okay? He is on all kind of medication for heart failure. He has EF of 55, hypokinesis, you know, it causes hypokinesis. He's on everything, clopidogrel, statin, nitroglycerin. He's on nitroglycerin, isosorbate, mononitrate. He's on all kind of beta blockers, Plavix, aspirin, everything. Okay, what would you do to prevent? Like, what is the best next step? In this case, you can add ranolazine. Okay. The way you want to do ranolazine, because it's treatment of chronic stable angina. So what is it for chronic stable angina? First line, you do beta blocker, like this patient was on beta blocker. Okay. Another thing, calcium channel blocker, added when beta blocker monotherapy not effective. This patient is already on there. Alternative to beta blocker when not tolerated. Nitrate, first line therapy for acute angina, long acting forms such as this patient is on that. After the patient is on beta blocker, isosorbate mononitrate, calcium channel blocker, right? So then in this case, what you want to do, you can add ranolazine. Okay. So this is basically, they just want to discuss chronic stable angina management. Okay. This is something. It's pretty interesting on how you. Okay. Another case they can ask about, like you will see, 44 came in with the cramps after simvastatin. This next step, CPK is fine. You want to check TSH level of thyroid, you know, because there are conditions like before blaming it on statin, you want to check, rule out alcohol-induced myopathy, thyroid disease, rheumatoid arthritis, SLE, electrolyte hypokalemia, Addison disease, Cushing, acromegaly, fibromyalgia, peripheral neuropathy, peripheral vascular disease, polymyositis, vitamin D deficiency. There are many other things that can cause muscle cramps and muscle damage other than statin. So before you blame it, check the other things. Okay, another patient, you see 25-year-old immigrant, okay, came in with fixed wide split of S2. So what do you find? What do you find on echo? That's the question. So you want to know which one. There's only one disease that causes wide fixed splitting. Okay, this is atrial defect, but not they don't ask you just for that. It's not in the options. So this causes right ventricular enlargement. They want you to know what ASD causes. So you know this is the third level of thinking. So they give you, okay, so clinical code for ASD: right ventricular heave, wide fixed splitting of S2, mid systolic pulmonary flow or ejection murmur, right excessive deviation, and complete right bundle branch block. Important complications can cause arrhythmia, atrial fibrillation, flutter, stroke due to paradoxical embolization, migraine headache, hypertension, Eisenmenger syndrome. So it can cause all of those issues, okay? Okay, another high yield case they can give you, a 71-year-old woman came in with late peaking systolic murmur at the right sternal border with S2 paradoxical splitting. Okay, whatever symptoms, she came in for like knee arthritis, whatever, like management, and they want to know what's best next step. So came for knee replacement and she had this murmur, and they want you to know what to do next. So in this patient, you want to do echo to check the murmur before you go further, okay? So active cardiac condition, this one they want to discuss. What is an active cardiac condition that increases perioperative cardiovascular risk? If someone have unstable angina, someone have heart failure, arrhythmia, like bradycardia, high grade AV block, supraventricular tachycardia, new onset ventricular tachycardia, severe aortic stenosis, like severe valvular disease, you know, like aortic stenosis, severe symptomatic mitral stenosis. So these things, you want to make sure that they are stabilized before you go surgery. Okay. If there's no active cardiac condition, then you can make sure it's low risk surgery or high risk. If it's high risk, then you would make sure the revised cardiac index is low. If it's high, then you want to make sure the metabolic equivalent high. If the metabolic equivalent is not high, then you still want to do echo. Okay. So these are the things that are very important, like case scenarios that you can encounter in real life as well. Okay, this is last question for this section. Is very tricky. You see 39-year-old came in with loss of consciousness, right? Loss of consciousness, and then other than loss of consciousness, the way they ask you EKG findings, EKG shows more than 2 millimeter curved ST elevation in the right precordial lead with T wave inversion and right bundle branch block. So the only, and they ask you about diagnosis, the only disease that causes this EKG finding, this is just remember it, you know, it's like there's, you can make logic of it, but this is Brugada syndrome, cause sudden loss of consciousness, and it's tricky, the only one that causes this, you know, right curved ST elevation, the right precordial lead with T wave inversion. Okay, and EKG findings, like very specific, look up EKG findings for that. Brugada. So okay, let's sort of review. We talked about Brugada, we talked about the one that causes paradoxical splitting. Which one is that does that? You do echo to check for it before you do surgery. right ventricular enlargement, TSH for statin. We talked about ranolazine, continue warfarin as well. Talked about mitral stenosis. Talked about liquid dash diet. Talked about aortic regurg. Okay. And that concludes our discussion for this section. Thank you for listening.